Hi guys, we are following up with where we left in lecture today at Piaget's Stages of Cognitive Development. So starting with sensory motor, which is birth to 2 years old according to Piaget, is going to be object permanence developing. We've really gone over object permanence and where it develops and when it develops. Pre-operational is going to be ages 2 to 7 years old, where egocentrism is available, and we've gone over egocentrism as well, and then the object permanence advancing. What I do want to do though is break down pre-operational. So pre-operational actually has two substages. The first is preconceptual, which is ages 2 to 4, and then the second is intuitive thought, which is ages 4 to 7. So between ages 2 to 4, that's the time where the child is pre-logic. Pre-logic, they're not going to be able to manipulate objects in relationship to one another logically. Their problem solving is only going to be based upon what is available right in front of them. They're not going to be able to recall information that was maybe presented to them yesterday or the day before. They also have an inability to understand conservation of matter. So conservation of matter meaning if I took 8 ounces of orange juice and put it in a short fat glass, and then 8 ounces of orange juice and put it in a tall glass, that is actually the same amount. They wouldn't be able to understand that yet. They are also engaging in magical thinking. So we did talk a little bit about magical thinking and literal thinking. Magical thinking meaning that calling children bad or saying that was a bad girl or a bad boy, they're not going to be able to differentiate between, oh, you're talking about the action that I just did was bad. They're going to generalize it, and they're going to misconstrue that information as, I am bad. What I am doing is bad as well as me. I do have this link for egocentrism here. I won't click on it now, but when you have time, if you haven't seen that commercial, the progressive lady, Flo, who does the commercials, this is the Sprinkles commercial, and I thought that now, while she's not talking to a child, she's talking to a grown man, her idea behind the whole talk is, she's building him up, you did a great job, but then in the end, she says, let's go get ice cream, and he's on board, he says yes, and then he asks if he can get sprinkles, and she says, no, sorry, sprinkles are for winners. So I think that's a good example of, magical and literal thinking that children of this age, between ages 2 and 4, within pre-operational, if you were to say that to a child of that age, they wouldn't be able to differentiate the information. They wouldn't be able to say, I get ice cream because I'm good, but then she says I can't have sprinkles because I'm not as good. So moving to the next stage of intuitive thought, ages 4 to 7. When we're moving into that, the child is going to be able to start seeing others' points of views. They are still, though, unable to think of all parts in relation to a whole. In concrete operational, ages 7 to 11, there's going to be a steady reduction in that egocentricity, which is going to help form the basis of that logical thought and the development of their own morality. Between the ages of 7 to 11, they are also fully aware of cause and effect and conservation. Some examples of all of these things are in this link at the bottom here, which is an excellent video. So I do ask that if you guys have not seen this video in earlier coursework, like in undergrad or something, I would go back and see the examples of each of these Piaget stages. It's kind of an older video, but it's perfect. Our last stage there for Piaget is going to be your formal operational, which is 11 to adulthood, where that abstract thinking ability does begin. And then idealism is certainly going to be present as well, because children in this age are trying to find themselves, and they do typically have some sort of ideology, whether it be something that is approved by parents or teachers, or peers is another question, but idealism is usually present. So I do encourage you to go back and view this video, because it does a nice job of, it's a psychologist interviewing various different children at various stages of Piaget's cognitive development, and it shows these examples throughout the assessments. Kohlberg stages of moral development. So Kohlberg basically says that disciplining begins at the pre-conventional stage. So you can see that the pre-conventional stage begins at ages 4 to 7. I think that most of us would say that parenting, though, begins sooner than age 4. But discipline, according to Kohlberg, begins at age 4. So that any discipline that we really try any sooner is typically going to be aimed at keeping the child out of harm's way. So preventing immediate safety dangers, holding their hand when crossing the street, or hurting themselves or hurting others, something along those lines. Now, whether or not they understand it is another question. But we've kind of talked about, some of the discipline that would be appropriate before the age of 4, such as maybe behavior modification, if they would really understand it. It would depend on how the parent would approach it, but the other form would be timeout. And again, that's not only to give the child a timeout and teach them a lesson, but it's also to allow the parent to cool off as well. All right, so let's begin at level 1. So level 1 is pretty straightforward, follows rules to avoid punishment, acts in their own interest, obedience for its own sake. So I'm doing it because somebody's telling me that I'm supposed to, and I don't want to get in trouble for it. So, and being in trouble means that I don't get to play video games, or I don't get to stay up late, or I don't get to watch a video, or I don't get to go outside and play with my friends. And I want to be able to do that. So therefore, I'm going to follow the rules. Level 2 is going to be our conventional, which is ages 7 to 11. So at that conventional stage, the parent's going to explain the cause and effect as appropriate with this age, but you want to give explanations and misbehavior and offer suggestions that are actually going to empower the children to fix the problems, or to fix the issue so that it doesn't continue to occur. So using that "you do it because I said so" attitude is an example of the type of parenting that more than likely might not end up working as well in the long run, but that's when this type of parenting may start occurring. And that type of parenting, just to remind you again, is authoritarian. So during level 2, we must be able to use that developmentally appropriate language. So between ages 4 to 7, we might be able to say things a little bit more simplistic, such as, "You don't do that because it hurts," or "because it makes her cry," or "because it makes your friend cry when you hit them," or "when you call them names." Because kids, are evolving out of egocentrism, it has to be very direct. It's not going to be as much of, "You don't do it because you're hurting their feelings," because again, between the ages of 4 to 7, they are evolving out of it, but how much they really care is another question. Maybe they do understand what feelings are now, but they are still going to look at themselves as being the most important. So between the ages of 7 to 11, still within that level 2, they're going to be able to begin to understand cause and effect and the intentions behind why the rules exist. So we're able to elaborate a little bit more, and they're able to also offer us their opinions during this conventional stage. The post-conventional is when not only are they just doing it because that's why they're supposed to be doing it, and because that's what the laws are telling them to do and the social system is telling them to do. But now, in the post-conventional stage, they've decided what kind of person they want to be or what kind of person they want to become. So based upon that, they are able to begin making some moral judgments. These next few slides are small. They're not meant to be giant, but I do think what's nice about it is that it gives you some examples of nursing application. So when it comes to, and what else is nice about it is that it does combine Freud, Erikson, and Piaget all in one. I just have it there for you to read through. There's nothing major about these next few slides that we didn't really already discuss. The only thing that is on here that we haven't mentioned a whole lot is Freud. I am not necessarily testing you on Freud in here. Not to say there may not be a quiz question, but testing-wise, we're going to focus more on Erikson, Piaget, and Kohlberg. The takeaway from Freud, I would say, would be your oral and your anal stage, just because it goes along with the safety measures. So, and the development. So during the oral stage for Freud, of course, they can put anything in their mouth. That's when we're going to offer sweeties. We're going to offer a pacifier. Sweeties is just sugar water, for example. I'm not sure if you guys are aware of that. But during the oral stage, that's how we can give a child comfort. But then the other piece of that is safety. They put everything in their mouth. For toddler, during the anal stage, that's when they begin to potty train. So that is certainly a big portion of their growth and development. Or at least that's when it starts. Here, I think that we've really touched on most of these things as we went through the previous slides, but feel free to read through those on your own. Same with school age and adolescence. A few more theories that they like for us to touch on with you guys. And even though we may not continue to maybe talk about the resilience theory or temperament theory, its concepts are certainly built into the course each week, really. Resilience theory is going to be the ability to function with healthy responses. And resilience is going to be possible if the child and the family's protective factors, so those things that protect them from disease, outweigh their risk factors. So risk factors are going to be those things that are going to predispose them to disease. Temperament theory is going to agree with Braun for Brenner, which is nature and nurture. I'm sure you guys have had nature versus nurture discussions in your past, Psychology 101 classes or even further. And in that, they say that people are both influenced and influence the environment. It does focus more on behaviors and personalities. Prematurity is something that we need to consider for sure, as well as in this box of additional factors that are going to influence growth and development. One thing that I did want to mention here under prematurity is just to not forget, reflecting back on that assessment voiceover, I said that if we were taking care of a child that was premature, how to figure out how delayed you would expect for the child to be. You would subtract the amount of weeks they were born early from 40. The reason why we do 40 is because that's how due dates are given to mothers. So if we expect that the child is going to be due on January 1st and they were born 2 weeks prior to that, we would expect for them to be at the developmental level of a 38-week-old when they are born. Or it could certainly be much more in depth than that. It could be months, right? Babies are born much earlier than that. They can be born, in the teens. They can be born in the 20 weeks. But if they were to catch up with where we would expect them to be growth and development wise, then we would expect for them to continue on that trend. We wouldn't continue to adjust their age based on gestation once they reach the expected growth and development milestones. Culture is certainly another one to mention that can influence growth and development, and we've touched on that a little bit earlier. Effective communication. You guys can read through this slide in and of your own. You guys know what communication is. I think that probably most, if not all of you guys are probably excellent at communication, and a lot of that comes with your experience and your age. Not that you're old by any means, but you do have some real world experience as opposed to undergraduate nursing students. So some more factors influencing communication and the nursing implications. This is much like the last table that I showed you guys that I think is nice because it does give you, some nursing implications based upon these different issues. We're going to go through each of the different stages, and some of this we have started to touch on a little bit, and a couple things I just wanted to expand on a little bit further. So for effective communication techniques for the newborn and infant, the sender of the communication, we know that they cry, right? So they cry and they smile and they laugh. That's about it. So what I want you to consider though is, does the child have the ability to communicate with me, right? So certainly thinking about a trait or a cognitively impaired child, they're not going to be able to communicate those things to us. So then how do we establish trust and mistrust, right? So every family is going to be a little bit different in that regard. Some families of, let's take the cognitively impaired child, for example, some of them, so they might communicate by blinking their eyes, or they might communicate via a grimace as opposed to a cry. Maybe they can't really vocalize it, but they grimace, or they're just quieter than normal. They don't make as many coos. And that's how we know that there's an issue, that something's going on. So that's definitely a very intricate and sometimes very private relationship that caregivers and the baby are going to have with one another. And as the nurse, that can be a really difficult thing, especially if those parents or caregivers aren't right there at the room. And that involves a lot of communication between the nurse and the parents or caregivers to figure out, how am I going to know what this child needs and allow them to get their needs met while you're either sleeping or while you're not in the room or while you're at work. So just something to, kind of think about. And I think that, me presenting a little bit of this information before you actually start taking care of patients does help you with some of that clinical paperwork, because the questions on your clinical paperwork packets are aimed at answering those types of questions. So the provider is certainly doing all of these things here in order to establish trust. All right, so looking at the toddler and preschooler, they can be a little bit more difficult to be able to communicate with. So, as they begin to ask questions as the caregiver, first, I would recommend finding out what they already know and what exactly they're asking, to be able to avoid giving too much information. So, I want you to remember that, because toddlers may ask you, or preschoolers may ask you, what is that thing you have in your hand? And because we are all very knowledgeable nursing students or nurses, we might have an IV in our hand, and we might want to go into some great depth, and we might want to tap into a little bit of their magical thinking, and we might want to say something along the lines of, this magical sword is going to go right through your skin, and it's not going to hurt, but it's going to provide you with water through those little tiny blue things that you see in your arm. So, having said that, kind of going back and re-listening to that again, first I said sword, that's kind of scary, right, to a child. Then I went on to talk about the water and in the veins and in the blue things, but all they really asked was, what is that thing, right? So that can be a little tricky, especially as you're working with patients and trying to answer NCLEX questions. So there is going to be some options that look like they could be the right answer. And you're going to need to kind of take a step back and do your test-taking strategy that you've learned to be able to answer NCLEX questions and decide, is that the best way to get the information across? Because we could have perhaps said that this is just a small straw that gives you water, right? And that could have been enough. And if more questions came, then we would answer them as they come. So, and the second piece to that, even though it seems like I just said 10 things, is to be honest. So you only want to answer what they're looking for an answer to, but you also need to be honest in the way that you're conveying that information. So we're going to address the parents, or address the child, but speak to the parents after the initial introductions. And we've already kind of gone through that, that you're going to introduce yourself, what you're there for today, what your role is, and you can address everybody in the room. But then after that, you want to establish a relationship with the parents, or whoever it is that the child already trusts, so that they see you're not a stranger, you're not an invader. Mom seems to trust you, dad seems to trust you, so it's okay for you to come up to them and do things like poke on them and pinch on them and squeeze their arm with a blood pressure cuff and things along those lines. Down on using therapeutic play when appropriate, just an example of therapeutic play when appropriate. I will show you guys some videos of that type of play, but an example of what therapeutic play could look like on a child of this age is if you were perhaps going to insert an NG. Child Life actually has dolls and puppets that are anatomically correct. They have holes for the nose where you can actually insert an NG into one of these puppets. So if you have a child who you need to insert an NG, they're probably going to rip it right back out after you put it in because they've never maybe been in the hospital before, or they are already feeling super anxious about this tube. Or maybe even mom or dad or caregiver was at the bedside and said, it's fine, they're just going to hold you down and put this tube in your nose. So now you have a freaked out 3-year-old, and we certainly can't say anything to mom or dad, but we can try to kind of undo a little bit of what that might have just done to the child. So we get a hold of Child Life, we get a puppet who's anatomically correct, has a hole in their nose that goes down to their fake stomach, and we will then allow them to help us. So we're going to show them what we're going to be doing, but they're going to be helping us at the same time. So they can feel the NG. They can feel that it's very thin and it's small and it's very flexible. And we're going to show them how the process works. And in the end, we're going to say, okay, so how do you think Sally felt when we did that to her? And they're going to answer, she seemed like she did okay. And then we can say, and what did Sally do while we were putting the tube in? And the child might say, nothing, she just laid there. And we can talk about that. So do you think when we may use this tube in your nose, you might cry a little bit? Because if it was my nose, I might cry a little bit. See what they say. And the child might say, yeah, I think I'm going to cry. And we can let them know, that's all right. So you're going to explain what you're going to be doing, and you're allowing sufficient time for the explanations and the questions, like it says there. And you can let them know that's okay for you to cry, right? That's okay because it's scary. This is new. That's completely normal. But what's most important is that Sally was really still when we were putting the tube in. Because if she moved back and forth and if she, swung her head from side to side, do you think then it might hurt a little bit? And the child would probably say yes. So I can't say that that's always going to work 100% of the time, right? But we can do our best to try to make it as less traumatic as we possibly can. So more toddler communication, preschooler communication. I've got some information, some examples here. We talked about Ivy earlier. Just instead of, staples, maybe use clicker or clicks because, it's associated with an office stapler or an actual gun. CAT scan, I think that's a good one. Maybe use special picture instead because if you say CAT scan, they might think that cats are actually involved. And they also don't know what the initials mean. If we say we're just going to do a CT scan, they have no idea what a CT scan is. So I think the rest of these are some really good examples as well. So just kind of eye-opening, as you read through those. Things that, as adults, I think we take for granted. For school age, I think that you guys can, read through these on your own, putting some of those principles that I was just mentioning before. We're still, of course, going to be open and honest, and we're still going to allow them to express themselves, just like I just mentioned when I went through the last slide. For the adolescent, what I think is probably the most important with the adolescent is that we're talking to them developmentally appropriately, but we're also, being sensitive to issues involving respect and privacy. They are going to want to have some of their own thoughts and opinions based upon everything that they're being presented with. So giving them some choices, for sure. So much like an adult. But at the same time, next week we'll get into, actually not next week, but the week after, we'll get into some of the ethical, legal issues that surround adolescents and, how much say that they actually have in their care. So we'll get into that in a couple weeks, but I think that what's presented here, you guys can read through. For the special communication needs, most of these things, are things that you're just going to have to experience. So we know, like we said earlier, that they're not fully going to be able to understand thoughts and emotions, but they certainly still have them, of course. We may have to do a lot of communication with the parents or caregivers to figure out what is the best way to communicate with this child. Most institutions, other than children's too, are going to have interpreters. They're going to have boards for them to write on. They're going to have, some of our trach patients are going to be able to use a Passy-Muri valve to communicate. So that's just, it's basically a one-way valve that allows for some air to pass through the vocal cords, but still allows the child to be able to breathe through the tracheostomy. So, so they're not completely capped. But those are things that, that do exist. And if we don't, a 2-year-old, for example, might not know to put that Passy-Muri valve on to communicate to us. So that's something that us as the nurse, we would need to be able to do that and then communicate with the child. So these are just all different questions, that I encourage you to ask before you're walking in the room or while you're in the room with the child. What is the best way to communicate to this child, and why is that? Is it because of their growth and development? Because they're typically developing, and I know that toddlers and preschoolers and school age always do it this way? Or is it because they have a specific underlying condition or a certain culture that influences the way that I'm going to communicate to them? All right, so a little bit more communication. So certainly we can consult with Child Life to prepare and support the family and to encourage that caregiver and family. All of that allows for the child and the family to have some control over the situation. Child life is even used, sometimes to help come in and educate the mom or dad. If this is something, if we've got a newly diabetic patient and we're needing to educate them on, now you're going to be getting sub-Q injections for the next 2 weeks while we're trying to regulate your blood sugar before we give you an insulin pump or something. What is the best way for mom and dad to approach little Tyler, and they're really great at those things. Using appropriate and timely medication and or topical analgesics to decrease pain, sensation, and anxiety. Describing what you're going to be doing and how it's going to feel. So that goes along with being honest. Now, you might not want to say things such as using analogies like it's going to hurt like a bee sting, or it's going to hurt like the worst pain you've ever felt in your life, right? Or it's going to hurt like a mosquito bite, because again, we don't really know what their background has been. So maybe they've had a mosquito bite in the past and they're actually allergic to them, and you forgot to look at their allergies before you came in. And the last time they had a mosquito bite, they swelled up and it was really hard for them to breathe. So what might be a little bit better would be to say something along the lines of, most kids say that it feels kind of like a poke, and some might say it feels a little bit like a pinch. When we're done, tell me how it feels for you, and then we'll be able to figure out if that's different than other people have felt. Relaying the most threatening information last is very important so that they hear everything else. I think that's kind of a given, right? Kind of goes along with health assessment where we say examine the most painful area last, right? Because if they hear all of the most threatening information first, then they're not going to hear anything else that you say. If you say we're going to be If you say that you're going to be putting a tube in their nose without giving them all of the upfront information, here's what we're going to do first, here's what we're going to do last, then they're probably not going to listen to anything else that you have to say. Giving the children a job and allowing for expression of feelings. That goes hand in hand with what I was giving you an example of when we put the tube in Sally the puppet. So it's okay to say ouch, it is okay to cry. The one thing that I want you to do the whole time is I want you to squeeze my hand and I want you to stay as still as you possibly can. Preparation materials are all going to be available through Child Life. A lot of the hospital floors have some of their own preparation materials as well. They have things as high-tech as iPads that have pictures of actual CT scans. They have recordings of what that MRI machine is going to sound like, because if you've had an MRI, you know it's loud, and that's very scary for kids. And if we have a 4-year-old, we would rather them just hear it and understand what's going to happen as opposed to sedate them, because maybe they've never had sedation before, because the risk might outweigh the benefit in that case. So we might be able to get them to stay quiet and calm for the whole MRI if we just prepare them efficiently. All right, guys. Well, that's all I have for you. We will continue on with some more next week. Thanks.